It's just a huge, huge honor for me today to be podcast interviewing my buddy for 30 years, Dr. George Tysowsky, DDS, MPH. He serves as Senior Vice President of Technology and Professional Relations for Ivoclar Vivadent. In this capacity, Dr. Tysowsky is responsible for research and development activities for all North American operations. He also serves as a clinical assistant professor at the State University of New York at Buffalo School of Dental Medicine and is a fellow of the Greater New York Academy of Prosthodontics and the American College of Dentistry. George has served as a board member of the American College of Prosthodontics Foundation for the past 9 years and is chairman of the board-elect for Oral Health America Foundation. Dr. Tysowsky earned a DDS degree from the University of Minnesota School of Dentistry and a Master's of Public Health from Minnesota School of Public Health. Now, George, it is my experience that every dentist I know who ever got their Master's in Public Health did it so that someday they may hold out the option of being a dean of a dental school. Is that going to be your next move? Are you going to do that DDS MPH so you can be the dean at Buffalo or somewhere?
Well, I'll play the corporate line. I'm very happy here at Ivoclar, so in a beautiful career here. So I'll pass on that one.
Okay, I'll call that a dodge. I'll bet you when George is 70 years old, I'll hear someday that he's the dean of Buffalo. But George, my God, we've known each other for 30 years. What are you passionate about today? I mean, I mean, the way I look at your and I relationship, when we got out of school, first there was the materials revolution, which took us from amalgam and gold to all this composite stuff. And then we went into the computer digital revolution, which is the CBCTs and all that stuff. What's the revolution of today? What's got you passionate today?
Well, it's all changing, Howard, as you said, and it's been an exciting era. And, really from our 30 years, dentistry has changed so much, and the young clinicians coming out today have whole new opportunities, new skill sets, new avenues to pursue dentistry. And as you mentioned, back in 30 years ago, we focused on 4 materials. We had gold, composite, amalgam, and PFMs. Today, the options of the digital workflow, computerization, digital access of information from the patients is completely different. And so the young clinicians today have to incorporate all those new technologies and understand their patients in a different way and introduce technologies in order to enhance their productivity in the workplace. So it's completely changing. I think we focused much more on materials back then, whereas today we're focusing not only materials, but the materials are an adjunct to the processes and how we fabricate and streamline our workflow in the dental practice.
I've always said, going back 30 years ago, that, I remember when they came out with the first laser. It was a $50,000 machine, and 1,000 dentists bought it. And then they went out of business. And I've kind of always believed that 1,000 dentists would buy anything. But it's really not mainstream until at least a quarter of the dentists get it. I mean, a quarter, mainstream practice management computer systems, everybody's got that. Digital x-rays, everybody's got that. But it seems like CADCAM, it's still, to me, it seems like it's still only sitting at about 15%. Is that about the number that you think in the United States? And if it, what percent of the dentists you think have CADCAM?
Yeah, you're right. You're right about that, Howard. It's a good number. I mean, the thing is, CADCAM's been around for how long? From the original CERC days to where we are today. It's really still at an infancy, but growing rapidly. And only about 15, depends who we talk to, 15, 20% maybe as far as penetration. But now, with the price point coming down, dentists are getting more involved with just getting scanners to try to introduce themselves into the digital workflow. And then we'll incorporate, as far as the full chairside milling process, as needed accordingly. But it'll continue to grow. Projections are that, digital chairside scanning will plateau somewhere around 50%. So there's a long way to go relative to penetrating that marketplace. And it's moving fast, but still at an infancy, but a big opportunity, and people are getting into it more and more as we go along.
Well, I think it's 15%. You're saying it'll saturate at 50%. I mean, what percent do you think have digital radiography? Well, let's go back to the most technology. Practice management computer systems as opposed to paper charts. What percent of the dentists you think have a practice management system? At least 80%, wouldn't you say?
I would say so for sure. It's a given today. If you have your workflows relative to your office systems, relative to the leading systems out there, it's got to be I don't know. I don't have the number, but it's 75, 80% a majority.
Well, you're in the great state of New York, and they just took an 85-year-old woman physician's license away because she wasn't digital. She was on the computer, and so she was writing prescriptions, which were all lawful, but you have to do it a special way, and they just took her license away. So digital's there. What percent do you think have digital x-rays?
It's got to be at least in the 70 percentile, I would think, coming up as well, for that matter. So the integration is really high relative to what we've seen as far as from practice management, digital workflow. The big new growth will be CBCT scans also. I mean, today, from placing implants, I mean, people are still doing it manually, but why wouldn't you? You have a whole guided process of incorporating the whole procedure. It's predictable. The outcome's guaranteed on that. So that's a big influx going through. But Howard, coming back, I think, relative to the clinicians today, it's a new era. There's our generation, which is learning digital technology, and the young generation where live it every day, from social media, integration, communication methods. We didn't have any of that before. So the adaptability is going to be at a quick ramp up and move in very quickly.
On my digital workflow, when can't I just take a Snapchat picture of the prep and send that to the lab? Do I need anything other than Snapchat?
It's going that direction.
Ivoclar is in dental lab and dental offices. I mean, in fact, you guys really actually started heavily in the lab business. I mean, when I used to talk to you guys 30 years ago, you had big lab divisions. What's the future of the lab and the digital workflow? When you and I graduated from school, the numbers I heard there were 15,000 dental labs in America, and now I hear that number's been cut in half. So what is digital workflow, and what does that mean for the future of dental laboratories, CADCAM, dentistry?
Well, I mean, we see all of dentistry, segmenting out. There will be the high-end, the comprehensive approach, and you need the expertise in that particular area. And then you have volume production and streamlining of, single tooth restorations. And so there will always be an expertise and a needed for complex cases, basically for a laboratory to be the coach or the advisor relative to the clinician of how to provide those complex cases. So we see a lot of high-end laboratories succeeding, growing rapidly. On the other hand, we see a lot of assimilation, a consolidation of laboratories today. There are big groups that we have from DSG, National Dentex, and others that have merged laboratories and centralized production, facilitating those type of restorative procedures. And so from a lab standpoint, I think the comment we always make is differentiate yourself. There's always room for excellence, and if you're at the top end, there will always be a need for that. But if you're just routinely manufacturing a single tooth restoration, that there are new efficient production methods that can enhance that and produce it in a rapid fashion that'll commoditize it, and that's why we have the consolidation that we have in the laboratory business. So we're very much involved in the laboratory business, but it's a different model today. I mean, people centralize their production facilities, so you may have a digital workflow where all the data comes in from different clinicians. It may go to a centralized production facility. People are creating milling centers and other factors for that matter. They then go back to the individual laboratories. The laboratories then can customize the restoration, but they're not necessarily fabricating the restoration. They're just characterizing it to the final prescription and then sending it out from the laboratory. But, complex implant cases, removable work, full mouth rehabilitations, combination cases between ortho and restorative, that's where the laboratory really plays a key role in being an advisor to the clinician and guiding them and being a partner in that restorative process. That's where we see the future going for the lab business.
Well said, and I agree. I mean, when you're doing a full mouth comprehensive case, nobody is chairside milling or anything like that. I mean, it's full impressions. It's with a high-end lab, all that kind of stuff. But the vast majority of the market. I mean, when I talk to Jim Glidewell at Glidewell, he says that something like 94% of the crowns come in 1 unit at a time. Is that the numbers
Right.
you're hearing?
We heard in the 80s, but it depends on laboratory, and
Yeah.
he's got great Of course.
So let's focus on my homies on that setting it one at a time. You know, the mass market single unit. One of the problems is that, you know, dental insurance started in 1948 when the Longshoremen's Union demanded dental benefits, and a couple of companies sprouted up. Later, you might have turned into Delta Dental. But in 1948, the maximum was $1,000. To keep that total real and constant dollars, it's in 2017, it's now past $10,000. When I got out of school, a crown was $1,000. I submitted that to Delta. They paid half. Now the model's changed. They send me the fee schedule, and it's $600. So these dentists out there, prices have come down 40% on a crown. So you have to compensate for that by doing your dentistry faster, easier, higher quality, lower price. You've mentioned digital workflow. So the majority of people listen to you. I think 95% of the dentists take a Delta, which gives them a fee schedule. So basically, factually, 95% of dentists participate in PPOs. If you're getting paid $600 for a crown, you talk about this digital workflow. Give us some tips on how to do that faster, easier, higher quality, lower cost when you got to work back from a $600 budget on a crown.
Yeah, so some people, depending on their practice philosophy and their standards, will utilize laboratories that provide more cost-efficient crowns, and it's a shopper's market today to try to find a commodity of what they can afford in that particular fee schedule. But many people move chairside, and the issue there is that to produce that kind of crown, you have to be fast and effective, as you just mentioned. So one-appointment crowns is really critical. The ability of speeding up that process, faster crystallization. We now have zirconias that can be fired chairside, so minimize the second appointment for that fabrication. The times of firing, for example, our EMAX restorations have shrunk down considerably, and there are millable materials. So like for class 2, large class 2s or fillings, we even have composite blocks that are available where you can mill them out, cement them in, and you don't have to fire them and go through the laboratory process accordingly. So I think the milling processes and the one-appointment visits have helped us control those costs, and dentists are continuously looking for materials that are fast, chairside, easy, and can facilitate and minimize that appointment time. So it's a big, big factor for us. Howard, I'm going to come back to you and ask you about that. I mean, you know the data better than I do, but I hear the reimbursement levels vary from provider to provider, and some provide up to $1,200 and some are at $600. Is that correct? I mean, it does vary across the country.
Yeah, 600 to 650 is the norm for a crown, for the majority. I mean, Delta on there, it's tough to say Delta, because if I said McDonald's, every McDonald's is owned by one company. But when you say Delta Dental, there's actually 19 different Delta Dentals. So it's very different. And of course, but yeah, I would, the trend is definitely, they're not raising the max of 1,000. They're not going to adjust that for inflation at 10 grand. And the fee schedules seem to be drifting downward. I mean, there's just no question about that. But I'm gonna back up, George. You and I forget that we've been out of school 30 years, and I always tell my homies, please email me, howard@dentaltown.com, and tell me who you are, something about yourself, your age, what country. But George, 25% of the emails coming in, they're still in dental school. And I only get like one email a month of anyone over 50, and they'll say, "Hey, dude, I'm as old as you." So podcasting is a 30 and under deal. I mean, really, do you even listen to podcasts? Truthfully.
This is my first one.
Yeah, exactly. I remember when I called up Gordon Christo to do a podcast 2 years ago. First thing he said is, "What is it?" And so it's a millennial thing, and they're in dental school. So I want you to go back to dental kindergarten, and what is the difference between zirconia and EMAX?
Well, so the new materials are evolving, as you mentioned today, and I think it's one of the most confusing things for young clinicians or experienced ones is to select the different materials. So there's different categories of glass products. We've had feldspathic porcelains that were used on PFM. They were really weak, below 100 megapascals, which is the breaking strength or fracture strength of these types of porcelains. We then moved into lucite reinforced, like products like Empress, which people won't even remember, or some people utilize still, but was the first glass ceramics that had better reinforcement and strength to them, and they were about 160, 180 megapascals, so we're jumping up the ladder in strength. Then we got into the lithium disilicate products, and aluminous oxide products were about the 400 to 500 range, and now we're around 500. And then the big breakthrough was the zirconia.
But wait, lithium disilicate, that was your Emax.
Right, I'll come back to that. I'm going to explain that.
Okay, I'm sorry.
And then the new generation products that we have for high strength, they're about 1200, which is the zirconia products. And these things are durable, can be used in bridge situations. You really can't, it's really tough to break these types of materials. But we've always had a balance of optics with strength. And so the nice thing about the Emax, or the intermediate strength products at 500, the lithium disilicates, was that it had tooth-like properties of aesthetics. You could cement or bond it into place, and it had very robust, durable properties and could be used in the anterior, posterior. And it was the first material that really superseded and allowed us to do an all-ceramic option versus a PFM or a metal-supported type of restoration. So that was the first generation that really dominated the profession, and you could fabricate it chairside, you could do it in the laboratory, and the dentist with the versatility could put it in anywhere and have a tooth-like, pleasing restoration that really enhanced the quality of the restoration. And they could cement it or bond it and reinforce it accordingly. They could use it for inlays and onlays, so a very versatile material. But today, when people are looking for high strength, they're moving into zirconia. And both products exist. Both are dominant in utilization, but the market is moving very heavily into zirconia because with its toughness and edge strength, you can do a typical PFM prep, you can feather it out, you can have thinner preparations at 0.5 in the posterior. It's not ideal aesthetically, but it's a white tooth-looking type of material, and it's not going to break. And so it's really taking a place of substituting for metal today, and that's where we have the zirconia. So it's a new breed, and young dentists are being educated on that quite a bit right now.
So basically, if it's a short, fat, bald grandpa, you'd put zirconia on the teeth, and if it was a beautiful lady, you'd use Emax?
Depends. Yeah, good analogy. But I mean, Emax for beauty, it can be used everywhere, but you got to have the preps and the definition. But if you want the optimum beauty, definitely. If you got thin clearance in the posterior and you want that thing to last, then it's zirconia.
Let me just hold your feet to the fire on a specific. When you look at the 32 teeth and you look at hundreds of millions of insurance claims, it's all the 6-year molars. I mean, it's the tooth most likely to have a filling, a crown, a root canal, an extraction. I mean, it's just you see a line, boom, that's number 3. Over here, 14, then 19. So you're in dental school and you have a crown on a 6-year molar.
Okay.
What would you use? Emax, zirconia? Talk them through what they should be thinking about deciding on the most common crown in the world, a single unit crown on a 6-year molar.
Sure. So I'm big on Emax, the lithium disilicate, because we now have the Zircad, which is the zirconia in that Emax family also. But if it came down, I got to do a prep. I mean, I typically would use Emax because the thing is, why wouldn't I would want the optimum aesthetics? It's got better translucency, better natural tooth qualities. And the durability is really unsurpassed. We've got 10-year clinical data with it, that has high 90% success rate, survival rates in those type of situations. So a very durable type of material.
What's your 10-year survival rate?
98.5 or something in that category. So it's above 95% for the lithium disilicate type of products. But the thing is that for forgiveness, the zirconia is a little bit more forgivable. So the thing is, if your prep's not ideal, you've got a feather edge margin, your clearance isn't quite a millimeter in that type of category, you don't want to bond it in place, then the zirconia is a little bit more forgiving. So me, I walk in an operatory, I got a first molar, I'm going to prep it for Emax, but if I have any compromised situation, I'm going with zirconia.
And are you going to cement it or bond it?
Ideally, the best is always bonding, but many clinicians prefer not to bond because the multiple steps. So I may use a self-adhesive cement, like our SpeedSem or others.
Give
or
the
I may
name SpeedSem.
SpeedSem Plus.
SpeedSem Plus.
Yeah, SpeedSem Plus is our self-adhesive cement that's utilized particularly for zirconia or for Emax type of restorations.
And is that
It's a self-adhesive.
Yeah, so go through the steps on cementing it then.
Yeah, sure. So the bonding agent is basically the adhesive properties are built into the cement. So it's got the monomers, which can react with the acidity, which can react with the dentin structure and provide an intermediate bond. If I wanted the full higher bond, then I would use Virulink aesthetic, for example, which I can use with the adhesives cements. Or the multi-link, which is our self-adhesive type of cement with a primer system. So we either have total adhesive systems or we have self-adhesive systems. So those are some of the variables that we can use for the cementation.
And which one would you use?
I like multi-link a lot. Multi-link provides rocket bonds. This thing locks things on and it's not going anywhere. So multi-link with you scrub the tooth for 15-20 seconds with the A and B primer and then seat the crown, and those bonds are over 40 megapascals. It's not breaking. It's not going anywhere. It's really locks into that lithium disilicate very, very well and provides basically replicating the natural tooth structure. So that's the ideal.
And I want to say one thing to the kids because when George said 20 seconds, that number just didn't fall out of his ear or his nose or his hand. It's so cool to go to these workbenches and you on extracted teeth and you scrub it for 5 seconds and do it, and then scrub it for 10 seconds and do it, and then 20 seconds and do it, and see the massive difference in strength. And when you see really elite clinicians, they always have a stopwatch back there. And you know who turned me on to that first was Michael Miller down in Houston. And when then he'd say, okay, this goes on 20 seconds. It's just hit the deal, and he'd scrub for 20 seconds. When you're looking at a clock for 20 seconds, it seems like 40 days and 40 nights. And you see these dentists. And Rilla Christian always tells me that. She says, dentists don't read the instructions. They don't read the instructions. So kids, when he said 20 seconds, it's 20 seconds. So be serious about that. But when you do the instructions correctly, it's amazing technology.
Yeah, Howard, you've been through the process, and I know Michael was an expert at it. But we have our applied testing center here, and we invite clinicians and we invite your audience to come in and visit us. But we run open houses all the time for clinicians coming through, and you can see that basically you're scrubbing that tooth, you cut down a half time, and you have like a bell curve, half time, then it shoots up to the peak and then degrades after that as far as coming through. So we try to optimize those and provide a window of forgiveness where we can optimize those instructions. So the numbers aren't just made up, they're all validated to the use that you're talking about.
So you would do, you'd prep it for Emax and you'd cement it with multi-link.
That would be the ideal. But the fact is, a lot of clinicians, though, just reality today from a usage standpoint, simplicity and convenience, some people just want a simpler process. They don't want to monkey with the bonding agent or whatever. So that's where we see the growth of these self-adhesive cements is taking off.
Is that kind of a, what kind of compromise is that on strength and efficiency? Is it a 5%, 10%, half?
50%.
50%. So how would you like to be getting your prostate surgery? And the doctor said, well, I'm gonna shave off 50% success rate because I want to do this procedure in 1 minute instead of 3. Could you imagine getting a bypass, and that's how the cardiovascular surgeon, by God, they're giving you $600 for a crown. You're not going to take an extra minute or two?
Well, that's what happens. People want to optimize that time. So the thing is, people will shave down the times out of convenience and productivity. It's just a fact. So we get a durable crown still with the Result, but true, I agree with you fully. Why wouldn't you go for the Optum if you can? But the issue is that people demand simpler processes and convenience. So it's splitting purity of the best to the practicality of the fabrication technique, the insertion technique. So it's part of our dental world today.
Okay, she just got out of the University of Buffalo School of Medicine, which just celebrated, what, their 125th year anniversary?
Yeah, I was honored. I was the commencement speaker.
I know you were. Congratulations on that, buddy. Would you... And now she's got $300,000 in student loans, so she's going to go set up her office. You talk about digital workflow. Would you recommend that she invest another $150 in CB in CADCAM, or do you recommend that she to oral scan that and send it to a digital workflow lab, or just good old impression material, polyether, polyvinyl siloxane, and a triple tray, and send it? We're still focused on just that single unit 6-year molar crown.
So I would recommend to the individual to tread slowly, getting involved in the technologies. First of all, invest in your office, set up your workflow. But as soon as you can, I would at least start with digital scanning. So I would buy a scanner, start that process, learn what you can accomplish with it. It's going to take over dentistry. I mean, it really was the new trend for communication, efficiency, opportunities, speed of process. Also, as a patient builder, I mean, today versus, sticking glue and impression material and choking a patient half to death as far as its different things. Scanning is the new trend and new incorporation. It will make dentistry more fun, more pleasing, more efficient, and more productive for the patient. So I think it's a great patient builder as well as streamlining our productive workflow.
Okay, but go through my 4-finger test. Is scanning over an impression material, polyether, polyvinyl, is scanning faster, easier, higher quality, lower cost? Does it meet all 4 fingers?
I think it's equal cost. Equal quality, because studies have shown that you get the same margins basically now with digital scanners as you do with PVS, for that matter. Cost, with a scanner, I mean, there are economic scanners coming out today, so I think that with the reduction in lab fees, because a lot of labs today will charge less. They'll charge 25% less for a digital input versus a polyvinyl impression coming in. So there's some lab savings in that particular direction. What were the other 2 points?
Faster, easier, higher quality, lower cost. You said the quality is the same. The cost, you're correct in the fact that a lot of labs say, I don't have to pay a human to pour this up in stone and trim it, so they give a discount. But faster, is it faster?
I believe so. I mean, the thing is, depending for a single unit,
faster and easier.
I think it's easier, and it's easier for the patient too. The thing is, you still have to retraction, but you're taking a picture. You're not having the stuff set up for several minutes and going through the uncomfort type of thing. So I think it is easier once you become proficient at it.
I know that you. I know that you and I know all these companies sell scanners, so I know you don't want to piss off any of your friends, but. What scanner would you recommend? Piss off everyone but one company. If you were going to buy a scanner just for George, what would you buy?
Well, there's a number of them out there, and they've all got their traits. 3Shape's certainly booming in their technology today. We have the CEREC, which is out there, of course, and E4D's coming on strong. They have a new economical scanner out there, the Emerald, I believe it's called. So Carestream's got one, 3M's got one. There's a number of brands out there, and they all have different packages. So the thing is, one has a user fee, one has an upfront cost. So I think you got to work with your dealer and kind of flush those things out.
Yeah, you're right. The all great points. 3Shape out of Denmark, they're crushing it. E4D out of Dallas, 3M, TrueDef out of Minnesota. Where's Carestream out of right now? Their scanner.
Carestream, I believe their headquarters in Atlanta. So Carestream's the old Kodak company.
Right.
So when they diversified, but now I know that their headquarters in Atlanta, I believe. So that's where they're coming out of. But every facility has different manufacturer. I think it's manufactured in France, actually.
Oh, really? And what's Carestream's scanner called?
I don't know, Howard.
Yeah.
I don't know if there's a trade name to it or not.
Okay, I want you to go back to that 6-year molar, because when you're in dental school, you're working on one tooth at a time. You're not doing full mouth rehabs. When you come out of school, the first 4, it's kind of like when you play football. You first need to learn just a tackle, a block, a pass, and a catch. You're not going to go out there and teach you some flea flicker play. So let's go back to that 6-year molar, and now it needs an MOD composite.
Okay. So
What would you recommend? I mean, she's hearing all these things, incremental layers, all the way to bulk fill. I mean, it's very confusing when one instructor is saying put down 2 millimeters cure, 2 millimeters, layer it against the wall and all this stuff, and then the next instructor is doing a bulk fill. So if she has an MOD composite on a 6-year molar, how should she do it? What should she use?
So it's a tremendous innovations in that type of area. I mean, when from previous technologies, we used to be curing 40 seconds per increment. We had initial composites that were heavily loaded with fillers and large boulders and things like that, and we had to build them up in very small increments and cure each layer. So as you said, it felt like it was taking a career to finish off one restoration. You're placing, curing was ridiculous. The lights have gotten tremendously better. First of all, we have stronger curing lights. So 30 years ago, the milliwatt output is about 500. Today we have 2,000 milliwatt lights available, most of them around 1,200 roughly. So we've doubled to quadrupled the light output on these curing lights. And so they're like hot flamethrowers. So we can cure these increments in 5 to 10 seconds, depending on what the need is of the material and how it's matched up. So that's faster. And then the new technology composites with these bulk fill materials have higher reactivity of initiators in them, so they're faster curing. So we can cure these increments in deeper depths. Four is a very reproducible number today. And so we can
4 millimeters?
4 millimeter increments, and then so we're reducing our time. So the speed up process on producing a filling is much more advanced, and so if you have large filling, you can usually do it in 2 increments and get a very viable restoration. And what's unique about these materials, they really changed. First of all, the initiators are changed, and then the other factor is that they actually have monomers that have relaxers in them. So they minimize the shrinkage, and they have a stress relief. So you're not taking like a big volume of concrete and trying to shrink it inside the filling. It's basically relaxing that type of area, so allowing the margins to seal and maintain themselves overall. They're really a nice trend. I mean, for a 6-year molar, like you're saying, a bulk fill is really the way to go. There's a variety of materials out there. They cure faster, they adapt better, they polymerize deeper. It's the new direction for us to move into.
So you'd recommend a bulk fill in 2 4 millimeter increments?
If it's a large filling, yes.
Okay.
Of course.
What's the brand name of the material you'd use?
We have Tetric Evoceram bulk fill is our brand, and we also have
say it slower.
Yeah, Tetric Evoceram bulk fill. Tetric Evoceram is our brand name, but we have a bulk fill version that's very, very popular today, and it's a great material. And we also have a flowable material that's quite unique, available for it also. Because what's nice about it, let me step back. A lot of the bulk fills achieve their depth of cure by increasing the translucency. So what happens is that sometimes these materials are so translucent your fillings can gray out on you a little bit. But we have a flowable, bulk fill flowable that you can coat the dentin underneath, and actually has an opacifier. So it blocks out the dentin and makes a more natural restoration. So that's Tetric Evoceram bulk fill flowable are the 2 brands that we carry for that matter. But there are other ones out there.
What about the bonding agent?
We use Adhese Universal as our flagship. It's a versatile
Universal.
Universal. Very high bond strengths. Again, in these studies that you've talked about, when you come in the labs, we're getting 30 megapascals routinely, which is you got to break the tooth before you break the restoration. So it's
go through the steps of using adhese. Is this? It's not a self-etching.
It is self-etching. You can use it self-etch, or you can use it as a total etch. It's got versatility in all different directions. So you can use it for partial etching, or a total etching, or self-etching accordingly. So you scrub the tooth, as I mentioned, for the 20 seconds, and then pre-cure it. You thin it out with air and light cure it, and then place your restorative material right onto it. And it can be used for directs and indirects as well. And it's got great sealing ability also. So the post-op sensitivity really drops down because it really penetrates and locks in your hybrid layer. So you get much more decreased post-op sensitivity with these types of materials.
Okay, her number 1 complaint on an MOD composite is the contact. Any tips for her there?
I mean, we have the new matricy bands that are available, not from us, but in general from Garrison and some of the other people that help out a lot in those type of areas. And then, I mean, we have to learn the manipulation techniques of making sure that we wedge properly and force the material into that contact area. I think a lot of people, if they use a smoother, more flexible composite, they just syringe it in and let the band take control of that area, and then we get loose contact areas. And so the ability of taking a plunger and forcing that material in the contact area while we're curing is really important to establish that contact. The matricy bands help a lot also by increasing the wedge space and providing some compensation for that. You know, Howard, the other thing you mentioned is that proximal contacts are definitely something that are critical, but post-op sensitivity is something that still comes up often. I don't know if you agree or not from your viewers and users for that matter, but nobody wants to place a nice 3-surface filling and then Mrs. Jones is calling him back at night on a Friday and saying, my tooth hurts, and you're chasing it down, and, you know, what are your repercussions on trying to handle that accordingly? But it all comes down to that bonding process. So, you know, I always say clinicians have to focus on those details and really just stop and focus on that tooth structure and pay attention to that dentin bonding process. So they want to make sure that they isolate the field properly, control the field. If they're using a total etch, that they rinse that off, minimally total etch, 15 seconds maximum, rinse off, and then saturate, and get that dentin bonding agent to penetrate into that hybrid zone. Because once they seal it, they got basically a Band-Aid there that'll hold and protect that tooth structure and not get any penetration. So the dentin bonding step is really critical as well in direct restoratives to minimize that post-op sensitivity.
You know, a couple things to the kids out there. You know, we talked about, you know, you want to go faster, easier, higher quality, and talked about how speed SEM is a lot faster, simpler, but the bond strength's only about half as multi-link. You know, you kind of get jaded after you've been a dentist for 30 years because, you know, it's the 80-20 rule when you practice. I mean, 80% of Americans don't care or take care of their teeth. I mean, they only floss twice a year, and you do it both times. You know, they come in, and, you know, they don't take care of it. So sometimes it's hard to strive for perfection when you know this patient's not going to brush it, floss it, take care of it. In my office, they come in with a Mountain Dew. I'm like, dude, do you take your bong to church? Really? Really? You brought a 64-ounce Mountain Dew into the operatory? I mean, really? So I get it. And I do tend to do far better dentistry on the 20% who actually care than the 80% who the only thing they ask is, you know, will my insurance pay for it and do whatever the insurance will cover. That's different. But the point I was going with that is we do all this great, amazing dentistry. I feel like dentists go out there and build this amazing Ivoclar Vivadent barn, and then 6.5 years later, the whole thing's eaten by termites. And I'm wondering how close we are for these fillings and crowns and cements to be antibacterial. Because, George, you and I know for a fact that when we got out of school, the majority of fillings were amalgams. And they lasted twice as long as composites because, hell, amalgam, well, it's half mercury. You're not going to find that in a multivitamin. The other half, silver. You see that in silver diamine fluoride with pediatricians. Tin, you see that in stannous fluoride with high. Every ingredient in an amalgam is not helpful for Streptococcus mutans to thrive, and now we're replacing them with amalgams are dead. They're dead to me for two reasons. The market doesn't want them, and the last straw for me was when I was reading the atmospheric mercury contamination. When you and I were born, the ocean was 1 part per million mercury. Now it's 4 part per million. It's from burning coal, and but when you study the mercury contamination, 6% of it is from cremating humans that have amalgams in their teeth.
Right.
6%. Right. So amalgam's really dead. But will we ever have a tooth-colored restoration that had the antibacterial properties of amalgam?
Yeah, so it's interesting you brought that up, and Howard, I know you have a passion for that, because I remember a conversation. We were having lunch at one of the ADAs, I think it was Orlando several years ago, and we had a new chief technical officer join us, and you were yelling at him for that matter of help help me provide a material that can prevent caries, especially in geriatric populations, root caries, and other. It's a huge need.
What a plague!
It's a plague thing. So coming back to that point, we've addressed that very heavily through a R&D initiative. And as you mentioned, the World Health Organization has made a call out of initiating and requesting manufacturers to find an amalgam substitute to try to combat this type of, fulfill this need that we're looking at today. And so amalgam has been easy, it's been economical, and it's been rather foolproof from placement and longevity, so that's the benefits of it. But for all the environmental reasons that you highlighted, it's time to move on. And so several companies, and we just introduced a new product called Sention N. And it's not available in the U.S. yet, but coming to Europe and North America, maybe next year, hopefully, for that matter, but evolving that direction. But basically, it's a highly bioactive type of material and utilizes a reactivity. Basically, it adjusts on acidity, so releasing calcium, phosphate, fluoride, and adjusting to the pH situations. So we've been doing extensive evaluations here in U.S. with universities like Kevin Donnelly at University of Texas, and with John Burgess in Birmingham, Alabama, and others. So we're looking at the long-term clinical trials. But what's interesting, these materials that are pH sensitive and adjust and basically react to the environment, adjust themselves, so they're ion adjusting type of filling materials that adjust to the acidity of the environment. So if you have a heavy bacterial attack, they adjust, release more, neutralize the acidity, and can combat that type of field. So it's a different chemistry than amalgam, but they're self-adjusting composites that react to the acidity and the attack in the different environments. So if somebody has a lower pH and has a clean hygiene and minimal type of need for that matter, it's just a stable composite type of material. It's composite based. It's not a composite essentially, but it is composite resin based, and it adjusts accordingly, and it can adapt to the challenges in the different environments. If you have somebody who has high acidity, a lot of plaque and bacteria, it'll adjust more and release more ions to try to combat that type of area. So it's a new direction in growth, and ourselves and other manufacturers will be going in that direction. The product I mentioned is called Sention N, and we're looking into introducing some sort of that technology in North America next year, possibly.
Where are you selling it now?
We went to underserved countries because the need has been so extensive, so it's in a primitive delivery format right now. A powder liquid type of format, and so it's sold in India, Malaysia, China introductions right now, and doing very, very successfully. But the clinical trials have been based in Europe and also in North America, and are doing very, very well.
So George, in America, about 4.5% will end up in a nursing home. So it's about 1 out of 20. And when you go into a nursing home, they're getting one root surface cavity a month. So if grandma's been in there a year, she's got 12 of them. So now she shows up on your door, and these young dentists are confused. I mean, they hear things, well, maybe you should use a glass ionomer. Obviously, an inert composite. Amalgam would be better, but even though she has Alzheimer's, her daughter doesn't want her to have an amalgam class 5s on all of her teeth. So if grandma showed up at your door, and by the way, you go into a nursing home, they're all women. There's only one guy in the whole nursing home, and his name's Lucky. And so what would you tell her to fill if grandma comes in from the nursing home? She's got rheumatism, she's got dementia, she's obviously not brushing, flossing, and she's got a bunch of root surface cavities. What would you fill them with today?
Well, coming back to your biggest point today, treatment of the elderly is one of the biggest concerns because they're the most underserved population available. I mean, if you have appropriate retirement plan and you have a family that takes care of you, you can get access to proper clinical treatment accordingly. But if you're left alone in a nursing home type of situation, not blaming them, but you have a visiting dentist who comes in once periodically, and so getting access to care is a real critical crisis that we have in this country for all the elderly. So we talk a lot about children, and we have a lot of programs. We have the national programs, school programs, and other factors try to bring kids to a dental home. for the elderly, many times that doesn't exist. So you've nailed that topic quite critically. On the restorative needs, it's a real critical factor. I mean, the root caries factor, like mushrooms growing around on the cervical areas, and they never stop for that matter. That's why we're looking at these bioactive materials that can be placed, user-friendly and active. So those are under development today. But you've got the glass ionomers are really the only standard of care that we have in that area, where you can basically patch them in, release the fluoride, at least stabilize the situation. But they're not going to reinforce the tooth overall because they have weak properties. And the more you go around cervically around the entire tooth, they're not going to reinforce the tooth. They're just going to seal and provide that antibacterial property through the fluoride release associated with it. So unfortunately right now we're limited. There are products like Gerastore, the new Activa's coming in different areas that we're moving into, our Sentian and others, but it's a huge need, and we have to develop more materials and techniques that are more user-friendly. You're not going to isolate that for a Class 5 composite on an elderly patient in a nursing home. It's not ideal, and you have to have materials that stick. They have bonding capability, ion release capability, and reinforcement capability, and can be placed efficiently and easily in those type of areas.
Yeah, I think it's a very, back to active ingredients. I think it's one of the biggest debates on Dental Town is, you take a 2-year-old and she needs a bunch of pulpotomies and chrome steel crowns, and she's obviously not cooperating, so you take her to an OR and put her under. Well, that's a highly dangerous procedure that at least every 3 months somebody's posting on Facebook, some little girl died and getting pulpotomy. So now there's a big movement. It made the cover of the New York Times with pediatric dentist Janine McLean treating it with silver diamine fluoride. And she's like, look, and there's a lot of research that shows that if a 2-year-old needs a bunch, or a 2 or a 3 or 4-year-old needs a bunch of pulpotomies, chrome steel crowns, well, when you get done treating it, there's going to be no change in the child's diet and home care. They'll still have the same parents giving it Mountain Dew and Cheez-Its. So 2 or 3 years later, the failure rate on that stuff is very high. And now you're seeing a big movement of saying, well, just come in every 6 months and I'm just going to paint them with silver diamine fluoride. The problem with that, though, turns the teeth black. And I was wondering if you think Ivoclar will, I've seen your research facilities. I've seen Liechtenstein. You guys are unicorn freaks. How many PhD research scientists do you guys have on your team?
Well, we have 170 in R&T. I don't know the breakdown of the PhDs. We got 170 in there.
Do you think they could ever make a tooth-colored silver diamine fluoride silver diamine fluoride is the bomb clinically, but it turns the teeth black. Why don't you guys make one in a white version?
Well, being worked on. If you had a portfolio, it's a different direction. We're working on all these type of avenues. Howard, I'm not avoiding that question, but I just want to come back. I think coming back to that elderly, I just want to make a point that it's the biggest need that we have in dentistry today. One of the biggest public health problems is treatment of the elderly. And I think you dedicated an issue to it several issues ago. I think you had a whole issue dedicated to serving the underprivileged and the elderly in that type of area. You mentioned before, I'm with Oral Health America right now, and we have a big initiative called the Wisdom Tooth Project. And again, trying to create awareness and some sort of a reimbursement and a ability of those people to find dental care. Finding a dental home for the elderly, they can be screened or whatever, but they have no homes and no access to get to. And that's a big, big need today that we have in social dentistry.
Yeah, and it's very stressful for my patients, too. Just the decision to find a nursing home for your mom. Even that is, just gut-wrenching. I got to go back to that 6-year molar on a filling. You said lights. When you and I were little, the lights were $500, and now there's lights up to $2,000. What light would you recommend she buy if she just got out of school? What curing light?
We have our Blue Phase style, which is fantastic. It's ergonomic. It's
Blue
pencil
Phase?
grip. Blue Phase style.
Spell it.
Blue, B-L-U-E, P-H-A-S-C.
Okay.
And then second word is style, S-T-Y-L-E, Blue Phase style.
Okay.
It's been rated the #1 light by the marketplace by Dental Advisor, I think in the 5th year already, so we're in the 5th year.
So where is that on the 500 to 2,000?
It's about 1,200.
And
so the benefit of it, the 1,200, it's pencil grip, so it's ergonomic, easy to use. It's got all the dimensions of timers and the 5-10 second cures, versatility, and it's fairly priced in that mid-level. If you're doing a lot of Emax and shooting full mouth restorative all day, then you'd move up to the 20i. The Blue Phase 20i would be the 2,000 milliwatt, and that's a hot light that runs very, very powerful. If you're curing through ceramics all day long, then that's a good light as well. The difference is the Blue Phase 20i is more gun style, and so it's a little bit more bulkier, but the Blue Phase style is our flagship and workhorse, and again, it has the highest ratings.
How much does that cost?
I believe in the mid 1200s, somewhere in there, Howard.
I just found your toothwisdom.org. Ryan just texted to me. Toothwisdom.org is a project that Oral Health America serves both seniors and their caregivers by teaching about oral health and aging, and by connecting individuals with affordable dental clinics. Who's in charge of that?
Well, I'm the chairman of the board right now, but Beth Truitt is our president and CEO, and so we have a whole staff in Chicago that's dedicated to that, and establishing partnerships with dentistry to try to communicate and develop the information and links to it. So they have a website that's run where we try to link patients and try to provide advice on how to provide a dental home, so patients can reach out to it, clinicians can reach out to it, and provide those resources accordingly.
Okay, well, on Twitter, they're at Smile4Health. And that's Oral Health America, and I'm just going to retweet their last tweet to my 22,000 homies following me on Twitter. Thank you so much for following me, at Howard Farran. That is amazing. But you said Beth Truitt's in charge?
Beth Truitt is our CEO, yes.
Do you want to send her on the show and talk about it for an hour?
Sure, she'd be thrilled. Absolutely.
All right, well,
fantastic.
Yeah, well, fix us up, and Ryan's the one who schedules. I'm a big fan of Oral Health America, and let me tell you how much I love it. I mean, Chicago is like the greatest city in the world in April and May and September, October, November. But Oral Health America, the Chicago Midwinter Meeting, they hold it in February. I mean, it's like I'm from Phoenix. I mean, to me, I have to put on a jacket if it gets below 60, and they hold that damn meeting in the middle of February, and that Oral Health America convention is it's like next to the water, so you have like this minus 20-degree wind chill, and every time I go to it, I know it's just going to be a death march getting into that place. Is there any chance they can move that meeting to April or October? I think the greatest meeting is the Greater New York meeting, because it's the perfect time to go to Manhattan. I mean, the Macy's Day Parade, it's right after Thanksgiving. The weather, you just want to walk around the whole city until your feet hurt.
It's fantastic. I know, but the Oral Health America thing is tied to Chicago Midwinter, so we do it in sequence. But this year it'll be at the Marriott, so it'll be a little bit more inland, so it won't be on the waterfront this year.
Well, they always, all these meetings like Yankee and Chicago, they always say, what do you think we should do to make the attendance better? Change the time of the year. Nobody wants to go to Boston or Chicago in February.
Right.
I want to ask you another thing. We're talking about Ivoclar's products, and you're talking to millennials now. You and I are you a grandpa yet?
Not yet. No marriages yet.
No marriages yet. Well, I can't wait till you're a grandpa, because it's the only thing that might be better than being a dentist. But yesterday. December 6th, Morgan Stanley warns dental investors that Amazon is here, sending shares of dental supply distributors Henry Schein and Patterson tumbling. Those companies both closed more than 4% lower Wednesday. By accessing dental supplies directly from a manufacturer, blah, 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 blah. But, you're talking to millennials. We're grandpas, and they're millennials. They buy everything on Amazon Prime. What is your prediction of one day being able to buy her Tetric Evo Ceram bulk fill on Amazon Prime, where she buys basically 80% of all the other stuff she uses?
Yeah, it's a tough question. First of all, we as Ivoclar have a very strong dealer partnership and have been working with them for years and are committed to our distribution partners. On a social culture, as you mentioned, just with Facebook and social media and everything else, internet buying is a fact of reality today, and they will come into play in some sort of fashion for that matter. So we'll see to what level they come into, but we did see them in New York. They had a small footprint there. Saw they have some partnerships with some companies, so we're watching the trend right now, Howard, for that matter. But it'll be a different world. I mean, as we've seen with the laboratory business today, consolidation, integration is something that's happening, and as we see with retail models that exist in this country overall, I mean, look at shopping malls in different directions, our buying habits.
I mean, things change. I mean, you and I are old school. We used to read books. Now you get on an airplane. I'm the only old fart reading a book. Everyone else is reading a Kindle or something digital, and I look at them next to me, and the reason it'll make me change is because I got to wear readers with my book, and I'm sitting next to grandpas and grandmas who just changed the font on the text, and that's what's going to get me to start reading digital. But it's just a change of text. But I guarantee you, these millennials listening to you right now, they're going to buy through Amazon Prime. I mean, that's just what they do. That's how they roll.
Yeah, I was saying before that our buying habits have changed, and utilizing internet and the mall pressures that we see mall reductions, so the model will change. The dealers will always be here and play a very critical role, especially depending on the partnership that they establish with the dealer rep and the dealer service, from equipment service and providing as a resource in different areas. So as the models change, we'll see where that pans out accordingly.
George, the one thing you and I have so much in common is that both of our commitment to continuing education, and that's another thing where millennials are changing. Millennials, we put 400 courses up on Dentaltown, and they're coming up on 1 million views. And these millennials say, I just go to the Dentaltown app, and on my iPhone, I throw it up on Apple TV, and I'd rather sit in my front room and take a course than getting in my car, driving down to the local state dental meeting and registering and signing in and all that stuff. They also prefer learning in hour increments, which is the research is showing. The research is showing that when you're teaching someone, they'll probably only listen for about 15-20 minutes. So going to an 8-hour course is kind of overkill. But what do you think about the future of continuing education and Ivoclar's commitment to continuing education?
Well, I mean, we still offer traditional analog courses where people come in and meet face-to-face and have the hands-on, and so I think there'll be tiers of education, but we live in a learn-now society with rapid access, and so the ability of getting information now is very, very critical. So whether you want to look up a procedure on YouTube, I mean, you can look up how to cement a veneer, you can look up how to do bonding or whatever, in different areas. You've done an outstanding job, Howard, what you've created as far as through Dentaltown, the access to the different videos that are available and that type of resource. But we see that people don't want to sit down for an hour. They don't want to sit down for 8-hour courses. If you look at the trends of general meetings in general, they're dropping. They're lowering as far as an attendance. But what's happening is that people are coming to the model of doing short snippets. So the AGD used to require, I believe, that you had to have an hour or 45 minutes to an hour of CE to get an hour of lectures to get a CE course credit. And now I think they've reduced it down to 15-minute increments. So there's different increments available for getting CE, but many people are taking a lecture or a topic. So let's say it could be on how to do appropriate dentin bonding. People are cutting into snippets of videos and information in 15-minute segments that add up to an hour to get the full picture, because people just don't have the time and the resources and the attention span to accomplish that. So quicker information, faster, sectional or broken up different areas of expertise will be brought up, but it's got to be fast, effective, and reachable by masses on a very rapid basis. So we're looking at that very rapidly. Website designs, online education, interaction, chat rooms, and I'm not trying to patronize you, but you are a pioneer and have established the whole value of the Dentaltown community accordingly.
That was the fastest hour in the world, George. I love you. I could talk to you forever, but I got one overtime question. It'll be my final question. Sometimes they get sad. There's some big threads on Dentaltown. They come out of school and they say, George, Howard, you guys were lucky. You graduated in the golden years, indemnity insurance, you submitted your own fees, dental school was cheap. I just got out of school. I got $350,000 of student loans. I got all these PPOs. And they ask you, they say, do you think she messed up becoming a dentist in 2017? Do you think you and I got out in the glory days? Do you think the glory days are behind dentistry? What would you say to her if she said, did I mess up choosing dentistry? Now I'm 25. I'm $250,000 in debt. You know, what would you say to that girl?
No, I think, I mean, very, very openly, I think it's the most exciting time to be in dentistry. And as you saw the rankings by USA Today, it's still ranked in the #1 profession several years in a row. And the benefit is the reward of the patient care as far as what you can provide for your patients. Two, economically, it's still a very rewarding profession. Sure, you're in debt, but if you build a successful practice, you can pay that off in a very feasible fashion. Speaking to numbers of deans, these people are coming out at $300,000 as far as in debt in different areas, but they're paying it off in a few years, for that matter. So the reward is there as far as pulling in, and then the technology and the opportunities. You're a healthcare practitioner in a leading profession, providing great care, providing great benefits to mankind overall. You're restoring quality of life. You're removing disease. You're maintaining health care. It's one of the best professions in the world and is being recognized that accordingly. So I think I don't know, we were in the glory. It was tough, Howard. In '85, it was very tough starting out. We had too many dental schools and saturation, and people are looking at getting hygiene jobs and trying to survive in different areas. I think we're in the glory years now, and it's a great profession. It'll continue to prosper in the future.
Yeah, I couldn't agree more. And whenever they whine to me about their $250,000 of student loans, I always say, dude, your first divorce will cost you $1 million. So, hey, thank you so much for coming on the show with me for an hour. Thank you, seriously, to you personally. You really have shaped my career. I remember you'd hear me saying crazy stuff on the lecture circuit, and you'd invite me down. You'd invite other speakers down. But you guys always, you guys knew who was out there lecturing the most, and you always made sure we always had great information. I can't even think how many times you've flown me into Amherst, New York, or someplace, and give us 2 days of just intense training. And you guys, you personally, really shaped my career. And your old buddy back in the day, remember Gary Severance back in the day?
Yep.
And your boss. I mean, I really like the way you took educating the speakers, making sure we had the right information, correcting us when we were wrong. I just think you've been really good for dentistry. I think Ivoclar has been very good for dentistry.
Well, great, Howard. Thanks a lot. It's always a pleasure and great seeing you.
All right, and send me that lady from wisdomtooth.org.
Oral Health America Wisdom Tooth Project. Well, I'll set you up.
Okay, buddy. Have a rockin' hot day.